Hi, this is Dr. Anjali. We'll talk in brief about eczema and various dermatitis. Okay. Patch testing is done for atopic dermatitis, irritant contact dermatitis, allergic contact dermatitis, or discoid eczema. So you need to know what each of them are to understand what patch testing is done for, and it is classically done for allergic contact dermatitis. So we'll start with atopic dermatitis. It's basically an endogenous eczema, right? It's from within the body. Uh, the diagnosis is usually clinical. There's no specific lab test for this, and we use the Hanifer and Raskas criteria, which has a whole bunch of major and minor criteria. Okay. The age at onset in atopic dermatitis is typically in infancy or in the first 2-3 years of life, and there's always a 50% chance one of the parents would also have a atopic history. Okay. The distribution of the rash is very typical. So in infancy, it's usually on the face, so on the cheeks, and sometimes on the extensor aspects. And slowly with age, in the next couple of years, it will progress to the flexural aspects, right? In the cubital and the popliteal fossa and the neck folds as well, as you can see here. The next two options, we're going to discuss irritant and allergic contact dermatitis. So there's some very basic differences between the two. In irritant contact dermatitis, it is an acute reaction. It is a reaction to a chemical or a substance that will affect anyone who has had enough exposure to that irritant, right? Whereas an allergic contact dermatitis is a type 4 delayed hypersensitivity reaction. So it will only affect those individuals that are susceptible to it. Irritant contact dermatitis is usually will occur with things like strong detergents, occupational exposure. So people whose hands are constantly in some chemicals or in detergents and water. Mechanical factors as well will be involved. There's a lot of friction causing disruption of your skin barrier. So very often hand dermatitis is usually an irritant contact dermatitis. Allergic contact dermatitis will tend to occur more often in a person with, say, atopy. So they already have a pre-existing damaged skin barrier, or someone who has leg ulcers, so the skin is already sort of damaged there. The reaction is not as fast or immediate as with irritant contact dermatitis. Now, most common allergens for ACD would be nickel, fragrances, and paraphenylene diamine. That is the color that is used to keep hair dyes strong. Irritant contact dermatitis, it will be strictly confined to the sites of application of the irritant. So it's very, very well demarcated. Whereas an allergic contact dermatitis can actually secondarily spread to involve the rest of the body as well, because this is a type of hypersensitivity reaction. In irritant, again, there will be more of burning and pain than an itch, right? Because this is like a toxic substance, and there could be swelling and blistering as well. In allergic contact dermatitis, there's more of like an itchy erythematous rash. And irritant is diagnosed clinically, whereas ACD is diagnosed typically with patch testing. You can pinpoint allergens sometimes with patch testing. Discoid eczema is basically nummular eczema, which means coin-shaped eczema, and it's a type of an eczema which is usually seen on the lower limbs. Okay. Most common precipient of contact dermatitis is gold, nickel, silver, or iron. So nickel is the answer. This is just something you need to know. Erythroderma, what is the percentage of skin involved? Straightforward question. The answer is 90%. Denny Morgan fold is seen in dermatomyositis, SLE, psoriasis vulgaris, or atopic dermatitis. So I've shown you a picture of what Denny Morgan fold is. It's that accentuated intraorbital fold of skin due to constant rubbing and irritation, of course, of the skin as well as itching. So this is seen in atopic dermatitis, right? For the other signs in autoimmune diseases, dermatomyositis and SLE, you should refer to the lecture on autoimmune disorders. Okay, there are lots of specific findings which I've discussed. So these are a few more cutaneous manifestations you can see in atopic patients. So eczema herpeticum, it's basically herpes simplex virus causing a herpetic rash, but it's more disseminated because the skin barrier is already disrupted in an atopic individual. So the herpes can spread quite extensively. It looks like an eczema. So eczema herpeticum is also known as Kaposi's varicelliform eruption. It is herpes simplex infection in an atopic individual. Molluscum contagiosum can also occur very easily when there's a disrupted skin barrier, and they can spread quite fast. Staphylococcal infections, or secondary superficial bacterial infections, are very common in atopic patients. So you can have impetigo in infants. You can have follicular pattern of atopic dermatitis in older children. Okay, you can have a lot of lichenification, as you can see on the hands of this child, and hyperpigmentation. Urticarial wheals are best described as pruritic, bullous, evanescent, or macular. So, most specific about urticaria is its evanescent nature. That means it's transient, right? It lasts less than 24 hours. It is pruritic. It is neither bullous nor macular, right? These are transient wheals, of course. Okay. Castle's necklace is seen in SLE, pellagra, lichen planus, or pernicious anemia. Straightforward question. Answer is pellagra. So pellagra is vitamin B3 niacinamide deficiency, causing the three features, the three Ds, that is dermatitis, dementia, diarrhea, and eventually ending in death. That's the fourth D. So it's endemic in countries where they have corn as their staple diet. So niacin in corn is in the bound form, not in available form, and the proteins in corn are usually deficient in tryptophan, which is the precursor for vitamin B3 niacin. It can also be seen in malabsorption conditions, so inflammatory bowel disease, any Whipple surgery patients. Certain drugs, isoniazid and azathioprine, can also precipitate pellagra, as well as carcinoid syndrome. So this is called metabolic steel syndrome because there is conversion of tryptophan, which is the precursor, towards serotonin rather than niacinamide. So you can see Castle's necklace over here. It's the rash occurring on the photo-exposed area. You will also have the pellagrous boot, so that's the exposed part of the feet, and the pellagra dermatitis on the forearms. You can also have mucosal lesions, so glossitis, that is of the tongue, inflammation of tongue, stomatitis of the oral mucosa, and chylitis, that is of the lip angles and the lip margins. Seborrhea and hyperpigmentation are also features. This is another deficiency. So dermatitis and alopecia occur in deficiency of magnesium, zinc, calcium, or copper. The answer here is zinc. So it is specifically called acrodermatitis entropathica, right? Primarily an autosomal recessive disorder, and you can see it also in preterm neonates, in those infants who are strictly formula fed because of the lack of zinc. Malabsorption conditions again, nephrotic syndrome because there's excess excretion of zinc, and certain catabolic states may be post-surgery, as well as in chronic alcoholism. So in zinc deficiency, acrodermatitis entropathica, you will see periorificial around the mouth, around the anal and acral dermatitis, so hands and feet, as well as of the genital, the scrotum area you can see here. There will be alopecia also, scanty hair, and diarrhea. So this can easily look like a diaper dermatitis as well, but then you will also see the periorificial dermatitis, right? So that's a clue. Which of the following is an example of endogenous eczema? Photodermatitis, contact dermatitis, atopic dermatitis, or infective eczema? So by now you should know the answer is atopic dermatitis. It is an endogenous eczema. Okay, the others are all due to some external factor interacting with the skin. Okay, sago grain-like lesions on the sides of the fingers is seen in erythema multiforme, dermatomyositis, pompholyx, and intertrigo. So the answer again straightforward: sago-like lesions like blisters, deep-seated blisters on the sides of the skin is Pompholyx, which is another type of endogenous eczema, right? You will see findings in all the other conditions as well. So try to recall erythema multiforme. You will see targetoid lesions on the palms. You can see on the target lesions. Okay, dermatomyositis. You will have your Gauthron's papules. You will have mechanics rash. Okay, mechanics thumb. And intertrigo, of course, is usually due to candidiasis. There will be maceration in between the digits. Characteristic of chronic eczema is erythema, induration, lichenification, and edema. Answer is lichenification, which means thickening of the skin, right? That is typical of chronic long-standing eczema, secondary to constant scratching and then resulting in thickening of skin. True about atopic dermatitis are all except pruritus, mica-like scales, flexural involvement, and xerosis. So, of all these features, mica-like scales is classical of psoriasis, right? Micaceous, silvery white scales. The rest are all true in atopic dermatitis. Following is a type of physical urticaria. Dermographism, urticaria pigmentosa, urticarial vasculitis, and autoimmune urticaria. So the answer here is again dermographism. It's a type of physical urticaria. So physical urticaria can be due to heat, due to cold, due to pressure, due to just touch. So this is what dermographism is. It's basically an exaggerated wheal and flare response to pressure, say by a pen or by any pointed substance. So you can have it also occurring in pressure urticaria, because there will be when there's constant pressure on some part of the body, say when you use your hand on your face, certain people can develop urticarial wheals over there at sites of pressure. So this is probably from the clothes, the lining of the clothes. The second photo is symptomatic dermographism. So some people have dermographism without urticaria. So just by scratching or by scratching a pen on the surface of the skin, they tend to develop the reaction. Doesn't mean they need treatment. This is just called symptomatic dermographism. And there's one more condition, cutaneous mastocytosis, that is also called urticaria pigmentosa. This specific condition, you get these hyperpigmented macules, as you can see here. And when you rub on it, say with the blunt side of the pencil where you have the eraser, when you rub on that, you will see those form a wheal. So that is classical of cutaneous mastocytosis, urticaria pigmentosa. So the answer is that dermographism is a type of physical urticaria. Seborrheic dermatitis is frequently seen in lipid storage disorders, psoriasis vulgaris, Parkinson's disorder, and cardiovascular disease. So a common association of Parkinson's disorder is seborrheic dermatitis. Hannifin-Raschka's criteria is for atopic dermatitis, contact dermatitis, urticaria, or psoriasis. Atopic dermatitis. In India, which plant causes dermatitis most commonly? So this you should know by looking at it. Okay, I'm sure everyone's seen this plant before. Is it Parthenium grass, cotton fibers, poison ivy, or ragweed? So in India, Parthenium is notorious for causing allergic contact dermatitis and photocontact dermatitis. So it's known as Parthenium hysterophorus. Okay, it's part of the Compositae family, also known as Congress grass. So this is a term associated with the US Congress, because this was introduced to Pune, to India accidentally, right, from a ship. And the actual molecule is the sesquiterpene lactones, which are responsible for causing the allergic reaction. Okay, sesquiterpene. And it is a type 4 hypersensitivity, type of delayed sort of hypersensitivity reaction. It can cause allergic contact dermatitis as well as airborne photocontact dermatitis. So this is very common. You don't have to come directly in contact with the plant. The pollen can just be airborne, and along with UV light it can react and cause an extensive dermatitis on all photoexposed areas. It can also cause a chronic actinic-like dermatitis picture, which again is on the photoexposed parts. The diagnosis of this is by patch testing with the plant. So here in the photos you can see the lady with a chronic exposed areas being lichenified, the face. This is a photodermatitis, and over here you can see the patch test with a positive. So one is the patch test. In the second panel you see a photo patch test. So they've done a patch test and they probably use the plant material. You can see a blistering reaction to the patch test, and the photo patch test is after you patch test and occlude the material. After a certain duration you expose it to a low amount of UVA light, and then you will see the reaction. Okay. Now these patch tests are typically read after 72 hours. Okay, that is also a question that's commonly asked.